Hey guys, I have tried to record this, I think thrice now, so please excuse me. I have quite the congestion, so if I have to stop to blow my nose at any point or I sound stuffy at any point, I'm just constantly sick from my children. So, the joys of parenthood. This learning module, we are going to be covering 3 different organ systems, but they are very closely related with each other. So as we're going through these, it would be beneficial to you to kind of have your notes available from the other 2 organ systems to kind of reference back and forth. So we're going to be starting with our biliary system, then we're going to move into our pancreas, and then we're going to finish off with our spleen. And we're going to kind of have a little bit of overlap between particularly the biliary system and the pancreas. So we will be referencing, kind of all over the place as we go through these recordings. So we're moving from our liver into our biliary system. Nice little segue. Pretty familiar with the gallbladder at this point, but we haven't really talked about it specifically. So the anatomy of the biliary system, pretty straightforward, right? Consists of the liver, the gallbladder, and the bile ducts, and how they all relate together. So the liver is considered its own organ. The biliary system is considered its own organ system, but the 2 of them are kind of interchangeable with each other because they work hand in hand. So overall, the biliary system is going to be responsible for the production, storage, and transportation of bile. And it's really interesting as we go and kind of learn more about this system because it's a very close relationship to our digestive system, and a lot of people don't realize that. So as we kind of go through some of our anatomy and physiology here, we're going to kind of touch base with our overall digestion. So the main purpose of the biliary system, or kind of the 2 main purposes, are 1, to produce bile, right, and the responsibilities that bile has, and then 2, to help drain waste products from our liver, right, back into our digestive system. So really the end point of our biliary system is going to be our digestive system to help get everything out. So it's going to help us aid in digestion with the controlled release of bile. Bile, as we know, is going to be a greenish yellow fluid. It's made up of waste cholesterol and, most importantly, bile salts. Those bile salts are going to be what breaks down and absorbs fat in our diet and helps with our overall healthy digestion. There are 2 primary functions of the bile in and of itself. 1, like we said, to break down the fats, and 2, to carry away waste. So it's sort of a vessel for other waste products to hop onto to get out of the gallbladder and get out of the liver. So pretty straightforward physiology with that. We will talk about that a little bit more when we get into our bile pathways. Gallbladder anatomy. We do know a little bit about this so far. We know it's going to sit in that main lobar fissure of a patient's liver. It's considered an intraperitoneal structure, which means it's sitting inside of the peritoneal cavity. It's nice and protected. It's usually going to be pear-shaped, but everyone's a little bit different. We don't necessarily care too much about measurements of the gallbladder, but you should know that on average, a patient's gallbladder will be 8 to 10 centimeters in length, 3 to 5 centimeters in width. What we do care about is the wall thickness. So we don't want to see the wall thickness greater than 3 millimeters. That's going to indicate a lot of emergent conditions and pathologies that need immediate medical attention. So next semester, when we start learning about pathology, we're going to be talking about that wall thickness a little bit more. And there actually is a condition where the gallbladder can be distended, and we actually would care about measurements of the whole gallbladder of itself. So we'll get to that next semester. So kind of keep that as like a little star in your mind that we're going to come back to this again. In terms of segmental anatomy, we do have a neck, a body, and a fundus. We're going to talk a little bit about how patients can vary, but the fundus is always going to be the widest part of the gallbladder. The neck is always going to be where that gallbladder tapers and gets more narrow, and the body is going to be the region in between the 2. And as we said, it's always going to be located within the main lobar fissure. Continuing on with our anatomy, so I had mentioned that I had tried to record this 3 times now, so these are my drawings from the previous recordings. But our gallbladder wall, we said, is super important in terms of measurement and kind of overall health of that gallbladder. We do have 3 layers that we have to be aware of. We have an innermost layer, the mucosa. We have a middle layer, the muscularis. That layer is going to be made up of a lot of muscle fibers and cells. So that's going to be responsible for contracting to kind of shoot out the bile, and also expanding when we have a lot of bile to store. And then we also have the serosa layer, which is going to be our outer protective layer. Between our inner mucosa layer and extending into our muscularis layer, we have these little pockets that hang out between the two. So there are these little pockets of mucosal layer that kind of extend into the muscularis layer. And these are going to be our Rodikansky-Aschoff sinuses. We don't see these on ultrasound, but they love to ask this question on your abdominal registry. So make a little star, make a little note that you have to be aware of that in terms of your anatomy knowledge. Now, if we're looking at our gallbladder wall, or really even our picture here on the bottom, you can see that our mucosa layer is going to be the layer that is touching the bile, right? So it's going to be softer, it's going to be a little bit thicker for protection, and that's going to be really what the layer that's touching our bile products is going to be with that wall. So continuing on with our biliary system anatomy, moving a little bit away from our gallbladder, we said the neck is always going to be where the gallbladder starts to taper. And taper into what? So it's going to taper to the point where it actually becomes this very narrow, very tortuous tubular bile duct. It starts to become a pathway for bile leaving the gallbladder. That's going to be our cystic duct. It's going to connect the neck of our gallbladder. It's going to join our common hepatic duct, which is going to be the pathway that's responsible for draining our liver. And the two of them together, when they join together, they're going to form our common bile duct. Now, we don't see the common hepatic duct, which drains the liver, and we don't see the cystic duct, which drains the gallbladder on ultrasound, but we do see where the two of them join together and they form our common bile duct. So imaging our common bile duct is very important. We will talk about how we can do that, what our picture should look like as we move through this PowerPoint. But just know that we don't see our cystic duct if it's normal, and we don't see our common hepatic duct if it's normal. So two kind of interesting concepts. We see our gallbladder, we see our common bile duct, but we don't see the two ducts in between. The cystic duct in and of itself, if you look at that picture, it kind of has like this really tortuous kind of spirally appearance to the duct. That's going to be the mucosal folds inside that pathway that we reference as spiral valves of Heister. Again, another registry question that they seem to love to ask every time. So we kind of talked a little bit about how patients' anatomy can be slightly different. We do know that the gallbladder is always going to sit in the main lobar fissure, but for each patient that can be located in a little bit of a different area of the liver. Sometimes we see it sitting straight up and down, sometimes we see it being kind of pulled posteriorly, and it's not going to change anything in terms of gallbladder knowledge, but what it does is it responds to gravity more uniquely, or it really is dependent on patient position. When you have your gallbladder sitting in that main lobar fissure in a very anterior to posterior fashion like this one, right? This one's sitting very straight up and down. Your fundus is going to be at the top, going to be more anterior. Your neck is going to be more posterior. So with gravity, we would expect to see gallstones kind of settle in that posterior region, right? Because of gravity, they're going to fall down. We're not going to see a gallstone sitting up in that fundus. Whereas the patient on the right-hand side, this would be an example of the gallbladder sitting more posteriorly in the main lobar fissure. So all of the bile, all of the potential gallstones, all of that is going to layer in response to gravity down at the fundus over here. So just be aware of that not every patient is going to have the same positional location of their gallbladder. They're not always going to look the same, and that's okay. None of that is concerning. None of that is considered abnormal. It's just going to be unique to that patient, and you have to be aware that just because you don't see a gallbladder in the way that you may be used to, that doesn't make it abnormal, and that doesn't make it harder for you to image. So it's a unique little organ in the way that it behaves from patient to patient. Kind of going back to a little bit more of that physiology, we're going to kind of talk about the responsibility of bile, right? And how does it kind of get the job done? Where does it go? What does it do? So we said the biliary system is going to function as a reservoir to store and concentrate our bile for when we need it to help us digest food. So what happens is as we eat, our duodenum says, whoa, there's food here. Like, I just got food from the esophagus. I need help breaking this down. So once food hits your duodenum, the duodenum sends out a hormone, cholecystokinin, and the gallbladder picks up on that signal, right? It's kind of like a little like distress call that says, hey, help me, I need help, I need bile, right? Send me bile. So the cholecystokinin triggers the biliary system to say, hey, expel bile right now. We got to break down this food. So that's kind of the initial response to the bile excretion. Now we do have technically two different pathways that bile can take, and one is either direct or indirect. They are very similar. The only difference between these two pathways is that the indirect pathway is when we're getting bile only in response to that cholecystokinin. The direct bile sequence is kind of this continuous pathway of bile that's kind of constantly flowing at all times. All right. So the direct pathway is going to be really kind of starting off both indirect and direct. Half of our bile is going to be considered a direct pathway. The other half is going to be considered indirect. Our liver, the hepatocytes, the functional cells in our liver, are going to produce the bile in and of itself. The bile is going to be stored in the gallbladder, okay, with the indirect pathway. With the direct pathway, it's going to kind of filter out through, well, really for both of these. The liver is going to produce the bile. It's going to drain into the biliary system by little ducts that sit in the liver. They all join to form larger ducts, and eventually we get that common hepatic duct. Our common hepatic duct, as we know, is going to join the cystic duct from the gallbladder. Two together are going to form the common bile duct. Common bile duct is going to exit out from the liver. It's going to reach the duodenum. It's going to enter into the duodenum, but before that, it's going to have the pancreatic duct join into it. And then from there, the two are going to enter in to the duodenum by what's called the ampulla of Vater. Okay, so that's kind of something that is always happening in the background. We're always having bile being produced in the liver. It's always kind of draining out of the liver through the hepatic ducts, into the common hepatic duct, into the bile duct, into the duodenum. The indirect pathway, like we said, it's going to follow that similar sense of entering into the common bile duct, entering into the duodenum. But prior to that, it's going to be the bile that's stored in the gallbladder as a reserve, right? And when our duodenum sends out that cholecystokinin, it's going to say, hey, I know you're kind of constantly trickling out bile at all times into the duodenum through that common hepatic duct, but I need whatever you have stored in that gallbladder right now. Because whatever's trickling through the common hepatic duct into the common bile duct into the duodenum, it ain't enough right now. Maybe I had a big pizza, right, and I need more. So that other 50% of bile that was produced by the liver that went to the gallbladder to be stored, now we're calling upon it. Now the cholecystokinin is calling upon it because we just ate something that we need a lot of help breaking down. So direct pathway always kind of happening, kind of bypassing the gallbladder a little bit, kind of going directly from the liver, draining out into the duodenum. Indirect pathway is saying, hey, yeah, all that bile that you had stored in the gallbladder, I need it here now. And it's going to kind of follow that similar pathway from that point on. So here is all of that pieced together. Here we have our gallbladder, obviously. Here we have our common hepatic duct. We said that all of the bile that's going to be produced in the liver is eventually going to drain into these little hepatic ducts that form a right hepatic duct, a left hepatic duct, joined together to form common hepatic duct. It's going to meet up with that cystic duct to form our common bile duct. That's going to head down into the intestines, and prior to entering into the duodenum, it's going to join up with the pancreatic duct from the pancreas and enter in. So pretty pretty kind of straightforward. It's like everything only really moves in one direction, right? And there's only one endpoint, and that's the duodenum. So pretty straightforward if you can just remember what the name of these pathways are and when one pathway would be used rather than another. Vascularity. So the arterial supply to the biliary system is going to be pretty straightforward. We have our aorta. The first branch off of our abdominal portion of the aorta is going to be our celiac axis. Our celiac axis is going to have a bunch of branches that come off it, but the branch that we care about is going to be the hepatic artery. That hepatic artery we know is going to supply the liver, and we mentioned that a bunch of branches come off the hepatic artery, and one of those branches that we care about is the cystic artery. So the cystic artery is going to supply our gallbladder, and in terms of drainage, it's a very complicated, what we call venous plexus, meaning it's kind of this, it's like this, I don't know, like if you've ever been like on an ATV course where there's all these different pathways that you can take and you're like, I don't know where I'm going. That's kind of what it is. They eventually will enter or empty through the liver or the portal vein. If it goes in through the liver, it will exit out through the hepatic veins. So it's, it's a complicated sense of drainage, but you have to know the arterial supply. So we have our aorta. We're looking at the abdominal portion of it. The first branch off the abdominal aorta is going to be the celiac axis. Celiac axis has three major branches that come off it, but the branch we care about is the hepatic artery. The hepatic artery has a bunch of branches that come off of it, and the one that we care about is the cystic artery, which is going to supply that gallbladder. We mentioned briefly in our liver module about portal triads, and this is when we're talking about the kind of close relationship between a portal vein, a hepatic artery, and a bile duct. All three of these structures are going to travel together throughout the liver. They're all going to be nearby. So if you see one, the other two are right next to it. There's a bunch of them in the liver, right? The portal vein and the bile duct are going to travel parallel to each other, and we know the hepatic artery is going to travel perpendicular in between the two. That's going to be wherever they are in the liver. This should be a little bit of a refresher. Our porta hepatis, that's going to be the area where everything enters or exits into the liver except the hepatic veins, which exit up at the top. The porta hepatis is where we have our main portal vein and our hepatic artery entering and our common bile duct exiting the liver, right? So those are our main portal vein, main hepatic artery, main common bile duct, entering and exiting. Main portal vein, hepatic duct, main portal vein, main hepatic artery entering, main common bile duct exiting. But we see the three of these structures in smaller versions traveling with each other throughout the rest of the liver tissue. Okay, how do we evaluate the biliary system? So mainly what we're talking about in terms of routine evaluation, it's going to be our gallbladder and our common bile duct. Our gallbladder, we want to see it anechoic. It's a fluid-filled structure, so it should appear nice and black. We want to see thin echogenic walls. We measure the wall in transverse in an anterior to posterior fashion. And we should see posterior enhancement because it is a fluid-filled structure, right? Fluid-filled structures are low attenuation structures. They produce enhancement. Our common bile duct, or our biliary tree, is a little bit harder for us to visualize, very small. So this should still be an anechoic tubular structure with very echogenic walls. We only want to measure the lumen only, so the inside aspect of that common bile duct. We're measuring inner wall to inner wall. We don't want to include the wall with a common bile duct measurement. We measure it in sagittal, so it's nice and elongated. And we measure from anterior to posterior, but only the anechoic portion. We want to measure the common bile duct distally, so we want to see it a little bit further away from the porta hepatis if possible, closer to the pancreatic head. And then we can use zoom to help us with our measurements, zoom to help us identify it. So we're really using that to our benefit. Now, if I were to measure this picture here, I would want to do so like such, right? Only measuring the inner anechoic lumen of that duct. Now, if I wanted to measure the gallbladder wall in transverse, I would do it. Oh, it's going to be really hard with this with this marker, like that. Just that hyperechoic echogenic wall in that transverse fashion. Remember, we're only always measuring that in the anterior wall, and we're measuring it anterior to posterior. Okay. The prep for any exam that requires evaluation of the gallbladder or the common bile duct is always going to be NPO, which means nothing by mouth, 6 to 8 hours. You have to have a fasting patient to have that gallbladder nice and distended with that stored bile, right? That indirect bile, that 50% that's going to be stored in the gallbladder. We want to see it nice and distended. When somebody eats, we say to the gallbladder, hey, I need the bile, so contract, shoot out all the bile, and the gallbladder gets really small and it contracts, and we can't see if there's a stone in there. We can't see if there's anything weird going on. So we need that gallbladder nice and distended, and only fasting can produce that. We're using our curved transducer, 3 to 5 megahertz, using a standard abdominal preset. This picture right here is what a contracted gallbladder is going to look like. Very small, very hard to visualize because we don't have that anechoic circle popping up on our screen. So it makes it pretty impossible for us to get diagnostic pictures of a contracted gallbladder. Protocol for looking at the gallbladder and the common bile duct. We're always obtaining sagittal and transverse pictures of our gallbladder. We want to be evaluating the mid, the medial, and the lateral portions in sagittal. We want to be getting a proximal, mid, and distal evaluation of that common bile duct with a measurement of the segment that's going to have the largest anterior to posterior diameter measurement. In transverse, again, we're looking at the fundus, the body, the neck. We're getting that anterior wall measurement. And then we also want to make sure we're documenting that same protocol in another patient position. So we're always taking our pictures initially in a supine position, and then we're going to roll our patient. We're going to have them decube. Sometimes we have them sit completely upright, especially if we think that there's a stone in there that we're trying to get to move around. Sometimes we'll have our patient go and walk around, come back, see if that gallstone can move or kind of wiggle out of wherever it's stuck. So you always have to provide pictures in at least 2 patient positions, supine being one of them. Our measurements, so what is considered normal, what is not. As we know, our gallbladder in and of itself, we don't particularly care about the measurements of the gallbladder. We're really not even taking measurements of the gallbladder. There are, like we said, some conditions that can result in an abnormally large or extended gallbladder, and we'll learn about that next semester. What we do care about is the gallbladder wall being less than 3 millimeters in an anterior to posterior diameter. Our biliary ducts, if we see anything other than the common bile duct, we already know that it's abnormal. So if we see the cystic duct, we shouldn't, abnormal. If we see the common hepatic duct, we shouldn't, abnormal. If we see a common bile duct, depending on the patient's age or medical history, the range of what is considered normal changes. So a common bile duct in a patient who is younger than 65 can only measure 6 to 7 millimeters at its maximum. We really only want to see it less than 3. That's going to kind of be our standard number, is less than 3. If we have a patient and the common bile duct measures, and if we have a patient who's over 65 and the common bile duct measures a centimeter or 10 millimeters, we actually still consider that normal, right? As we get older, that bile duct gets more dilated. And then if our patient at any age has had their gallbladder removed, we let that kind of have a wider range of what's considered normal. So anywhere from 6 to 11 millimeters can be normal if you don't have a gallbladder. That common bile duct kind of overcompensates for lack of storage, and it gets a little bit bigger in response to that. So we should only be seeing a common bile duct. If we see common hepatic or cystic duct, not normal. If we have a common bile duct that looks really dilated, anything really over 3 millimeters, we got to kind of look at the patient's age. And then we also have to look at their surgical history. So we don't freak out if someone has a 11 millimeter common bile duct measurement if they don't have a gallbladder. It's just normal for them. Normal variants. So I think we had a couple of these in lab already. So you will see some of these more frequently than others. A Frisian cap, that is going to be something that a lot of patients have. It's when the fundus portion kind of folds itself over the body portion of the gallbladder. That's going to be this guy right here. And a Frisian cap, I don't know what Frisian stands for, but a cap like a little hat, right? A Hartmann's pouch, that's going to be where we have a fold between the neck and the body of the gallbladder. So kind of at the opposite end of that, that's going to be this guy right here, right? So it's kind of folding more towards the neck portion of the gallbladder. A junctional fold is when we have a fold right in the middle. That's going to kind of be this guy up here. And then true septations, super rare. It can be a sign of a bigger problem going on or a precancerous sign. That's going to be this guy right here. Sometimes when you have a Hartmann's pouch or a junctional fold, you can get it confused with true septations. So what you want to do when you see those is really sweep through that and make sure that you see at some point the inner lumen of the gallbladder connecting with the next segment. You will never see connection between the segments of a gallbladder that has true septations. So it's rare, and chances are it's usually going to be some kind of other normal variant, but you do want to make sure that you're truly ruling it out because it can be a sign of something bigger going on. So we're going to move into our pancreas PowerPoint. So I'm just going to stop this one.